Today we are very lucky to have Dr. Mehdi Rahimi, renowned endodontist from Sydney, with us today, and he's been presenting for the last 4 days over the last 2 courses at Advanced Endodontics. In Clinician's Corner this month, we are talking about the topic of cracks in teeth, and I know for a lot of our viewers it's something that presents a clinical challenge. So Mehdi, tell us how you normally diagnose and treat cracks in teeth.
Okay, so it all comes down to, if you're suspecting a crack, taking a careful history from the patient, because sometimes the patient will tell you the diagnosis by telling you they might have bit on something hard like a cherry pit, an olive pit, and then remember it's been hurting ever since. Whenever I do my diagnostic sieve, of course, I ask about the type of pain. Some of those patients that have cracked teeth may have hot and cold sensitivity. Some of those patients will tell you they have chewing pain, and even when you ask them before you do your tests, let's say with a fracture finder, tooth sleuth test, or a cotton roll bite test, you actually ask them, is it painful on biting downwards or is it painful on opening? And they'll say, oh, okay, when I think about it, it's more painful, or I get a sharp pinch when I open the mouth. So you know straight away, okay, it's telling you there might be a crack in the tooth, whether it's a crack that's restorable or unrestorable.
What if it's painful when they bite down? What does that mean?
So when it's painful when they bite down, it could be a variety of things. It could still be a crack, but it might be related to the periodontium. Often food traps can cause pain on biting down, and even an endodontic lesion where the tooth is somewhat inflamed, it's not sort of asymptomatic, can be sensitive to biting on downward pressure. So the one where they say, when I open, I get a sharp pinch, is almost always a cracked cusp or a cracked tooth.
Right, and so how about the duration of the pain? I know from clinical practices, some patients, they go, oh, it's painful, and then it's gone really quickly, or some patients go, oh man, that pain lingers for a minute or 2 minutes or half an hour. Yeah. What is that to you?
So often, if you, it could be different. Like it's not always like, pathognomonic. It's not pathognomonic, but it's highly suggestive. If they say it goes away quick, it could be a crack that may have not quite involved the pulp. However, you will go in and you inspect, you illuminate the tooth, you use magnification, and you may have to assess further by a clinical investigation. But at the start, if they say it starts to linger on, you're wondering if it's sort of a pulpitis. If it's a pulpitis, then probably the crack is more near or has affected the pulp. Whether you can still preserve the pulp and do pulpotomy, or whether you have to then go for more definitive restoration. So if it's a definitive restoration, you might even do the endo, if it's restorable, in case the crack might have even gone down and involving the roots, might have gone below the crestal bone, for example. Those type of cracks are unrestorable anyway.
And so is this all done before you take a PA, or do you take a PA first?
Well, the nature of pain, the diagnostic sieve, the chewing pain, and the hot and cold sensitivity, and is it throbbing, and all of those sort of tests, sharp, all of that's asked before I actually do my radiographic and clinical examination. So my first thing is I spend quite a bit of time asking them questions to see the nature of pain, the type of pain. Because occasionally they come in and they might have TMD. There might be bilateral, the type of pain they have. It might not be related to a cracked tooth. But one of the biggest hints when you talk to the patient is they might remember they bit on something hard, or it's pain on opening. And that's the two.
Like when you bite down, then release.
Yeah, on release. Yeah. That's right. So those are two hints to telling you, okay, I'm dealing with a cracked tooth, without even doing any radiographic clinical examination. And then of course I move on to my next examination, which is, it's again a process, it's a method which I obviously do so many times, so I am highly unlikely I'll miss a step. So from examination of the mouth, looking for signs of wear, anterior wear might indicate more likelihood of a sleep apnea patient, because when they lie down it blocks their throat. They may bring the lower jaw forward to create room for breathing, and those sort of patients will do a lot of anterior wear, and they can also have cracked cracked teeth, because at night time they'll do really weird, rapid, because they're trying to breathe, jerk action movements, because the masseter is quite a strong muscle. In fact, per surface area, the strongest muscle in your body is your masseter. So you look at signs of stress, you look at signs of apnea, you look at, so you take a history of that too. You don't just look in the mouth, but inside the mouth you're looking for wear, you're looking for plunger cusp, you're looking for missing teeth, you're looking for the history of what happened to this tooth, when did you lose this tooth? Oh, 6 months ago you lost this, and 2 years ago you lost that. It's an alarm sign, it's telling you there's something going on. This patient is just left and right, domino effect, cracking their teeth. There's got to be an underlying reason, whether it's stress, whether it's apnea, nocturnal bruxism, daytime bruxism. There's lots of different reasons. So that's the first thing. Then you look at the restorations. Okay, are these teeth restored that you're dealing with, or are they unrestored? Again, the unrestored tooth that becomes non-vital or cracked is got a downhill scenario. It's going to fail. That's definite in the literature. But if it's a large restoration, you wonder if it's the restoration that caused that, together with the ongoing cyclic chewing. So therefore, you remove the restoration, you assess restorability. You have to remove the restoration because you need to see what's there. Not only you'll miss stuff, like maybe caries that's difficult to detect on a radiograph, possibly a crack that is on the margin that you don't see if you don't access. So you must remove everything to look carefully at what you see, and then you diagnose the thickness, the ferrule of dentine, and cracks. And often you'll see craze lines, but craze lines are not always cracks. Cracks are sort of more separated. And I tell patients, craze lines like in pottery, or on a wall you might have a crack, but it's not actually a slip, separated type of crack. So you assess the crack. Is it vertical? Is it horizontal? Horizontal cracks have a better prognosis because you can reduce the cusp. Vertical ones that involve the crestal area, they seem to go under the gum. They might go down the R5 of the root canal. They're just not worth often saving. Some cracks are borderline. You illuminate, you're not sure if it's a craze line or crack. You may decide to brace those teeth, commence endo, review in 6 months. If no deep pocket develops, if the patient's symptoms go away, you might put a direct restoration, a less expensive restoration, and finish the endo. Maybe delay that even another 6 months. So you buy time so that if there is a failure, you haven't taken all of the patient's money. You take the money slowly. and that's logical, right?
Yes.
Because radiographic analysis, one of the things that people don't realize is that we use a lot of CBCT endodontists, and people go, why? One of the most important reasons why I use a scan is to look for the chimney defect or lateral bone loss along the root. A lot of times when you look at a good quality endo by an endodontist, you're wondering why. I can tell you almost always it's less likely to be bacterial from miscanal anatomy, because we're getting better at agitating irrigants and getting to where we need to. It is often actually the fact that we missed the crack. So on a cone beam, you'll be able to see bone loss, that subtle bone loss that travels along the root, or the bone loss in the middle of the root where you've got bone above it and bone below it. Highly suggestive of some type of crack.
Well, they are great radiographic tips and great clinical tips. I think if people are interested in learning more about cracks, come along to the next AHC Dental Ed Endo course, where Dr. Mehdi will be discussing this in a lot more detail, so you can get very confident clinically about cracks. So, Dr. Mehdi, thanks again for your time, and we'll see you everyone next time.